let's go ahead and get started here. We're on lecture 2 of the 16 part lecture in the Haynes Method Hybrid DN Certification course. Again, the 16 lectures with the 4 lab sessions. Here, lecture number 2, cervical and lumbar. So let's just kind of get right into this here. We've already talked a little bit about the structure and the format of the course, and so we will move on. What we're going to go over today in this 2-hour period is first we'll talk about just some housekeeping to do, required supervision by PT, OT, any clinician with a subordinate PTA, CODA, or whichever, I guess MD to PA, that sort of a situation. We're going to then talk about, look at specific surface anatomy and 3-dimensional anatomy. We'll talk about specific needle placement, location, the description. We'll look at a little bit of some supporting evidence that's out there. We'll talk about clinical decision making, and then finally we'll get into our specific structures. Today, the axial spine, the posterior cervical spine muscles would be Splenius Capitus and cervicis. In the erector spinae group, we're going to look today just at spinalis cervices. Longissimus and iliocostalis cervices we'll address in an advanced course. And then also Semi-Spinalis Capitis and cervices, and then the Multifidus. We'll look further into the lumbosacral region. Here we're going to talk about Interspinalis Lumborum, the Longissimus and Iliocostalis Lumborum, and then Multifidus, and then just a surface area of the Psis. So, conversation here about required supervision. Practice of physical therapy often involves a multi-staff approach to treatment that may involve more than one PT or OT, or may involve a PTA or a CODA, or more than one. In a perfect scenario, it is ideal for the same clinician to remain the only clinician treating that patient throughout the patient's course of treatment. That scenario is not always possible or even practical. Clinicians call in sick or go on vacation or move on to other opportunities. The patient still needs to be treated and their care managed in a consistent manner. And that is just as much the case, if not more, when dry needling is included in the treatment plan. It's incumbent upon each therapist to gain proper training and competence in dry needling before practicing the technique on patients. It's even more incumbent on the examining or supervising therapist to ensure clinical competence of the subordinate treating clinicians that they, 1, have the clinical competence to perform dry needling in a safe and effective method, and 2, that the subordinate treating clinician has the training and the approach that the supervising clinician has prescribed in their treatment plan for that patient. Specifically, the supervising clinician should establish specific treatment parameters based on defined protocols that both clinicians have demonstrated competency. The subordinate clinician will have the ability to withhold treatment but not modify or add to the established treatment protocol based on the patient's condition. If there were adverse events that took place in one of the needling locations, such as bruising, increased soreness, etc., then it would be permissible for the clinician to modify or delete that treatment point. Communication between the patient and the treating clinician and the treating and supervising clinician is of the utmost importance in the PT, PTA, or OT, CODA treatment relationship when utilizing dry needling as a treatment modality. It would not be appropriate for a supervising therapist to allow an assistant to alter the treatment protocol, except for withholding certain treatment locations due to adverse events, without discussing the case with the supervising therapist first, and only then with approval of the supervising therapist. If the treating therapist is on site, it would be ideal to discuss the adverse event with the therapist prior to treatment to discuss other options. At a minimum, the assistant should discuss the adverse event with the supervising therapist before the patient returns for follow-up treatment. The therapist and assistant treatment team is responsible first to ensure no harm to the patient, and second to utilize the dry needling protocols taught to the most effective benefit of the patient. From a legal standpoint, and in parentheses, I am not an attorney, I cannot provide legal advice. However, from a legal standpoint, inadequate supervision on the part of the PT would make the therapist potentially liable for any adverse event that occurred due to the negligent acts on the part of the assistant. Negligent acts would include ignoring established danger zones and contraindications established as part of training, as well as altering the established treatment protocol without documented consultation with the therapist. The Haynes method of neuromuscular dry needling is structured to teach its students the safety aspect of dry needling, but to also teach specific treatment protocols that establishes the structure necessary within the therapist and assistant framework for the supervising clinician to establish the treatment protocol or protocols to be implemented, and the assurance that upon completion of the certification process, the assistant would be clinically competent to carry out the dry needling protocols that are part of the plan of treatment, and would further ensure the communication between the two clinicians that is vital to proper execution of the dry needling protocols. Moving on to some supporting evidence, we'll talk about some cervical first. A study by Gildeer from 2019. It's a randomized trial of trigger point dry needling versus sham needling for chronic tension type headache. Again, we're talking about trigger points, which if you've listened to my lecture, I'm not a trigger point advocate and solely basing treatment based upon that methodology. However, here they actually used actual dry needling into specific trigger points in specific muscles. And then they also used sham needling. And what is sham needling? They simply place a guide tube on the skin, tap the tube, but don't actually insert a needle. So the results here in the dry needling group, intensity, frequency, and duration of the headache and the scores of the short form 36 subscales were significantly improved after treatment. In the dry needling group, all the effect sizes for headache variables were large. The conclusion they came to, the results of the clinical trial suggest that trigger point dry needling in patients with chronic tension type headache is effective and safe in reducing headache intensity, frequency, and duration, and increasing health-related quality of life. I can certainly vouch for the benefit of adding dry needling to your patient that presents with headache symptoms. Certainly you want to look at other aspects, but dry needling is a great way to reduce the overall neuromuscular tension in that problem. Next, it is a study by Tazun. This was back in 2017. It's the effectiveness of dry needling versus classical physiotherapy program in patients with chronic low back pain. Here they compared the effectiveness of dry needling with a classical physiotherapy program with patients with the chronic low back pain caused by lumbar disc hernia. The results in the study group, the calculated Cohen's effect sizes were bigger than those in the control group in terms of pain, trigger point related variables, and fear of movement. The effect sizes for reducing depressive symptoms were similar in both groups. The conclusion, these results suggest that dry needling can be an effective treatment for reducing pain, number of trigger points, sensitivity, and kinesiophobia in patients with chronic low back pain caused by lumbar disc hernia. Again, our anecdotal evidence in the clinic, as well as our research, definitely indicates that dry needling can be an effective approach to managing low back pain. It definitely has to include some additional therapy. So the idea that dry needling alone fixes a problem is false. We must include our strengthening, our flexibility, our return to activity components as well. So a couple of studies there on some recent supporting evidence. We'll move on and talk about our clinical decision-making process. So when I make a decision, I look at a patient to evaluate what we want to do. They're having some gross pain, diffuse pain, maybe it's some focal pain let's use the example of a shoulder. I want to look at all of the movement systems involved there in the shoulder. I want to look at the scapulothoracic spine. I want to look at the cervical spine, maybe the first rib. A lot of different structures we want to look at. So in our case today, dealing with the cervical and lumbar spine, dealing with the cervical, the regions, the movement system that we have to look at, it would be both the cervical and the thoracic. We need to look at the scapula and its function, its involvement with the cervical spine as well. We need to evaluate what's happening at the CT and the ST junction, and then again at the costovertebral junction. So quite a few things that could come into play when we're dealing with a cervical pain. And the lumbar spine in the right-hand column, again, we also need to look at the mid to lower thoracic spine. We need to look at the lumbar spine and see if there's any abnormality taking place there. We need to go further and look at the sacrum and into the pelvis. A lot of our pain that we have described to us as back pain frequently is further down onto the sacrum and laterally into the pelvis itself. Need to look higher at the thoracolumbar junction, and again further down at the lumbosacral and the sacroiliac junction. When we do this, we want to make a strong assessment, and I add some pieces whenever I'm considering adding dry needling. So definitely we want to look at our myotomes. What is our strength like? Do we have one muscle in that movement system that's got some deficits? Range of motion, is there some flexibility issue? Is there some capsular involvement? Is something happening that range of motion is not normal? Is there some asymmetry, one-sided versus the other? And general movement patterns, both with the cervical spine, we would want to look at the definitely the range of motion of neck flexion, extension, side bending, rotation, but we would also want to move a little bit further laterally. Look at the scapulothoracic movement. We would want to look at the movement pattern in the shoulder. We would then want to go through some palpation and look at their pain pattern. Is it just a focal pain? When we think of the lumbar spine with the SI joint, is there a thumbprint of pain that we're dealing with? Is it a focal dialed in, or is it radiating? Is it something that's going from mid-cervical? Is it radiating out through the upper traps laterally towards the shoulder? Does it go further down in the shoulder, or does it even go past the elbow? We want to evaluate all these areas for specific tenderness, and when we do that, are we having specific muscles involved? Can we identify each of the structures that are involved? The muscles that are involved will give us a good idea of what other structures we need to address. For example, if we're looking excuse me, in the cervical spine, looking a little bit laterally next to the shoulder blade. If we identify that upper trap is a problem, then we may want to look a little bit deeper at levator scapulae. Does that muscle tenderness, is that focal tenderness translate further laterally towards the acromion? Is it coming more medially centralized to the articular pillar, or even higher up toward the mastoid process? All of these decisions, all this assessment gives us a really good idea of what potential structures could be involved that we need to potentially include in our treatment approach. And then we want to talk about or take a look at our any altered sensation. Is it a dermatome, follow a dermatomal pattern, or is it more of a peripheral problem? In our dermatomes, we can see, and we'll look momentarily at our dermatome map, that, does our altered sensation follow that? Or is it more, which would indicate a central spine problem, say a bulge, a compressed nerve at the foramen, or is it more peripheral that would indicate a more lateral entrapment type of a problem? We do perineural dry needling at the sites of entrapment, and they can make a difference. So identifying that altered sensation can give us another idea of where we should be applying our needling technique. So in our clinical decision making, where to needle, what protocols are we going to throw out here? We'll look at in the cervical spine, we want to look at first, we'll do some cervical vertebral springing. Cervical springing isn't quite as easy as is the lumbar spine, simply because it's a much smaller space. But if we can do some springing in the prone position and find some areas that are or some segmental levels that are more inflamed than the others, then that gives us a good idea of where we need to dial in. As far as palpation for specific cervical tenderness, we would want to start at the external occipital protuberance, and we can take that all the way down to T4. And here we're going to look at the paravertebrals on both sides, and we can palpate that muscle belly from the spinous processes laterally all the way to the articular pillar. Once we are looking more at our anterior structures, we can palpate around further anteriorly, say to sternocleidomastoid. But for this posterior piece, we would want to palpate all the way to the articular pillar to determine if that tenderness is more centrally or more laterally displaced towards that pillar. We want to get at the center suboccipital, laterally towards the mastoid process, and then down to the transverse process of C1. So there, we'll see this more with people complaining of headache. We'll find a lot of significant tenderness, and we'll talk about that when we talk about our specific three-dimensional anatomy. So we want to palpate in that suboccipital region there. And we want to palpate up and down, cranially to caudally, on the articular pillar as well. The scalenes, and there's a lot of other structures that attach there laterally, and a lot of times we'll identify some inflammation in those structures that without good palpation skills, we just wouldn't know that that's happening. So palpating laterally on that articular pillar is important. Want to assess the upper trapezius. Again, it's a large muscle, covers a lot of territory. There aren't many treatment approaches in the upper quadrant, cervical spine to mid to lower thoracic, that don't have some involvement of upper trapezius, not necessarily from a pathological standpoint, but definitely from a neuromuscular tension standpoint. So evaluate that upper trapezius specifically. Sometimes middle and lower get involved, but normally it's that upper trapezius part. And then we want to evaluate the superior angle of the scapula. I mentioned the levator scapulae. We'll talk about this in the advanced coursework, but the levator scap there at the superior angle of the scapula tends to act like the upper body version of the piriformis in the lower body. It just gets a lot of inflammation from movement dysfunction, not necessarily tears or anything like that, just inflammation and muscle tension. So I definitely want to evaluate that. And what we're doing when we do this palpation, we're looking for the tender bands or nodules. It'll feel like whenever you find that muscle, that structure with that tension in there, you'll be able to follow the longitudinal fibers of that, and one that's involved will feel like there's almost a pencil laying underneath the surface of the skin, and that is going to be your ideal location for needling. Fortunately, whenever we get to those structures, the protocols are laid out to really be effective at hitting those areas and getting that improvement in neuromuscular tension. Again, we also want to look at can we cause aggravation or provocation of their symptoms through either active movement, passive movement where we move the body part, or resisted movement. Any of those things could be indicative of or helpful in identification of inflamed tissue. In the lumbar spine, we would look at, again, the vertebral springing. That can really help us dial down very specific levels. When we get to the lab portion, we'll talk about some specific areas that we practice dry needling. But when we find a specific area, say it's a higher lumbar level, if we know that they've got a positive springing test at L2, then that's the location where we want to do our dry needling down to the lamina so we can get deep to the multifidus. So springing can be very helpful there. When we're palpating for tenderness in the lumbar spine, we want to go from T12 all the way down to S2. These are all structures that can be helpful for us to identify, again, in the paravertebrals from the spinous process laterally past the iliocostalis, and we'll discuss identifying that border. We want to palpate the iliac crest. A lot of structures attach onto the iliac crest, especially from the apex more midline on the posterior aspect. Definitely want to look at the Psis, although no structures actually attach onto the most dorsal surface of that Psis. A lot of structures are coming very near to it, and there's a large fascial or soft tissue attachment around that, and Psis almost always has some aspect of tenderness associated with it when we're dealing with lumbar and lumbosacral problems. Additionally, a little bit further medially there, we want to look at the SI sulcus, as we'll talk about Iliocostalis, longissimus, and even multifidus to a small degree with their termination or attachment in that sacral sulcus. A lot of tenderness can be associated there and give us a keen idea on where that needling needs to take place. Again, we also want to try to identify those tender bands or the nodules, find that pencil inside that tissue, that longitudinal tissue, and then can we aggravate or provocate that symptom through their active, passive, or resisted movement. So still on clinical decision making, looking at sensory deficits. Again, the idea is, are we dealing with a impingement in the central canal, at the foramen, at the central, at either of those two areas, or is it further lateral? If it is in the spine itself, secondary to herniated nucleus pulposus or osteophyte or some sort of action that's causing some impingement there, then we'd anticipate that sensory deficit would look more follow these pathways. So say it's L4, we would see it fairly low, and then we would see it cross laterally and then anteriorly across the kneecap, coming on down to the medial aspect of the foot. If we, and this is just a simple, it's a three-dimensional dermatome map, just rotating on its axis to get a view of what these patterns look like in a three-dimensional approach. For some people, this is a helpful way to view this. I thought I'd include it in case somebody is that. It can be downloaded if you want for your perusal. And so we also wanted to know, is this a peripheral problem? So as nerves exit the spine, they follow specific courses through fascial planes beneath different muscles in different areas. And if the nerve is on a specific aspect of let's say the posterior calf, posterior cutaneous nerve of the thigh, S1, S2, S3. Well, there would be a specific location of entrapment away from the spine that would reproduce that. So you have to make a differentiation between a dermatome pain pattern and a peripheral pain pattern, and that will give you an idea if you're just needling into that spinal region or if you're going to try to find that area of peripheral entrapment. So let's dive into some three-dimensional anatomy. Here we will take a look in the cervical spine. 1, 2, 3, 4, 5, 6 structures here, and then we'll drop into the lumbar spine and look at 5 structures there. So in the cervical spine, first we'll take a look at Splenius Capitis, and we'll just go through the nuts and bolts of the muscles here, and then we'll pull out and take a look at it from a three-dimensional standpoint. So Splenius Capitis, its origin, the lower half of the nuchal ligament and the spinous process of C2 to C4. It inserts into the mastoid process and the skull below the lateral third of the superior nuchal line. It's innervated by the posterior rami of the cervical nerves, and as we go through most of the spinal nerves, we'll find that they're innervated by the posterior rami. Occasionally there'll be a little bit of variation, but we'll cover that. Their action in most all of these posterior muscles, their action is to draw, in this case, the head backward, extending the neck, and individually it's going to rotate to the same side. So here's some information that came out of Henry Gray's Anatomy of the Human Body. A lot of our drawings and illustrations come from this text. It was written in well, he was 1825 to 1861. It was re-copyrighted in 1918, and since that time, the copyright has gone by, so it's in the public domain now. Anyway, I'm not going to read all of this to you. It's there for you for your leisure to read. Most of it we'll cover in more modern language, but good information to have there. And so next we'll look at the splenius cervicis. So here our origin, the spinous process of T3 through T6, and then insertion is into the transverse process of C1, 2, and 3. So this is a long muscle, and we have a separate way that we needle this down in the thoracic spine, although its main effect is up into the upper cervical. So here again, innervation is the posterior rami of the lower cervical spinal nerves. In its action bilaterally, it will extend the head and neck. Unilaterally, we'll get lateral flexion to the same side and rotation to the same side. In the erector spinae group, here we're going to limit ourselves to the spinalis cervices. Again, there are two other iliocostalis cervices and longissimus cervices that we'll address in the advanced cervical lecture. Those are needled on the lateral aspect, and we need to get a little bit more experience before we jump into those areas. But in the spinalis cervices, its origin, the lower part of the nuchal ligament in the spinous process of C7 and sometimes T1 or even T2. It inserts into the spinous process of C2. And again, innervation is through the posterior rami of the spinal nerves. Its action, it is the smallest of the subdivisions. It interconnects the spinous process of the adjacent vertebra, and it's most consistent in the thoracic region, and it can even be absent here in the cervical region, where it's frequently associated with this deeper Semi-Spinalis Capitis. So this is one of the rare situations where this muscle has two distinct bodies, both in the cervical and thoracic. If I put the thoracic piece, it would look like two distinct muscles. Then we'll move on to the Semi-Spinalis Capitis. So Semi-Spinalis Capitis, and we'll look at it again in a three-dimensional in a little bit, is very notable for our tension headaches. These are not the deep suboccipital muscles, but very frequently with headache on the, let me bring my mouse over here, on this medial border on either side. Anytime that there's a tension headache, there's a palpable band of dense fibers running longitudinally, and that's a really nice location of needling. We'll just needle directly into that onto the occiput there. So Semi-Spinalis Capitis, strong bread and butter muscle for treatment. But in its origin, the transverse processes of C7 and T1 through 6, and the articular process of C4 through 6. Its insertion is the medial area between the superior and inferior nuchal lines of the occipital bone. And we'll talk about that surface anatomy or our landmarks. This basically makes up that footprint between the superior and inferior nuchal line. Innervation is the posterior rami of the spinal nerves, and again, its action bilaterally pulls the head posteriorly, and individually it pulls it posteriorly and rotates. The semi-spinalis cervices. So here at origin is the transverse processes of the upper 5 or 6 thoracic vertebra, and it inserts into the spinous process of C2, 3, 4, and 5. Innervated by the posterior rami of the spinal nerves, its action, it bilaterally extends the vertebral column and individually turns or rotates in the opposite direction. And then the multifidus, here our origin, and we'll cover this again when we get to the lumbar, but our origin is going to be the articular process of the lower 4 cervical vertebra. Now that's just in the cervical component. It is actually much lower down onto the sacral body itself. But for purposes of cervical spine, it's off of that lower 4 cervical vertebra. It inserts into the base of the spinous processes of all vertebra all the way to C2. It's innervated by the medial branch of the dorsal rami, and this is one where it's a little bit different than the posterior rami. Here it's the medial branch. Its action, it's the prime stabilizer in local movements of the entire vertebral column. Global movements, they contract bilaterally to extend the vertebral column, and they contract unilaterally to produce rotation in the opposite direction, but primarily they are a stabilizer. As far as the innervation on the medial branch of the dorsal rami, my anesthesiology, pain management physicians are very fond of performing either a medial branch block or a radio frequency ablation. Well, when they do that, it is the medial branch of the dorsal rami that they are targeting. And while they may at times provide some pain relief there, they're doing it at the expense of innervation of the multifidus. It is this person's opinion that may not always be the wisest choice. We need these muscles to do their job. Doing it at the expense of that stabilization for pain management, I feel like we can probably do a better job with our dry needling, quite honestly. And so I don't mind going head to head with those guys and trying to get a patient under control with their pain prior to targeting those specific nerves. Let's see here. All right, so our posterior cervical spine, our surface anatomy lab. And so let's look at our three-dimensional view of our structures. I've got, in this particular example on the right-hand side, I've removed some of the superficial musculature. I've taken away the traps and a few other things to pinpoint out this long structure of spinal muscles that we're talking about. I'm going to highlight here in just a second. There we go. Our longissimus travels, as its name implies, travels a long way as it's traveling up even into the cervical spine. Further laterally, we'll see the Iliocostalis as it's traveling up, and then we'll start getting into some of our other musculature, our spinalis, the thoracic spine, and then we had mentioned one of the muscles coming way down that attaches actually on 1, 2, and 3, has a nice needle location at T4. But let me jump over into our cervical spine itself. Let's talk about these muscles in a three-dimensional view. Again, I like this three-dimensional approach simply because it gives us a really good orientation of where our needles are, where they're headed, and it provides a nice treatment approach there. So let's start deep. Very first that we want to look at is our spinalis spinalis surfaces. And let me close that so that we can break this down a little bit. So our spinalis surfaces, or spinalis colli. Let my computer catch up. Apparently I'm asking it to do a lot. And there it shows us alternative names. I'm not in charge of naming of all these things. I just know how I was taught. Now they want to call it spinalis colli, and that's perfectly fine. So there again, you can see its attachment all the way down to C7, T1, T2, and comes up a little bit higher onto the spinous processes, C2 through 4. And obviously it's a deep muscle, and I'm going to point this out in a bit. When we get to the actual needling, we're going to find out that lateral to the spinous process of C6 is where we're going to put one of our needling locations to get our biggest bang for our buck. We want to get as many structures as we can with as few needles as possible, and so I selected C6 simply because it's the center point of this particular muscle. We move a little bit further laterally to that, and we'll get the semi-spinalis surfaces, or colli. It has a little bit further orientation as far as its attachment all the way down to T6. It inserts in the spinous process of C2 through 5, and again, it's a little lateral to, say, the spinous process of T4, so it'd be hard to needle that this far down. But if we drop back up to the spinous process of C6, which is right here, is that fiber muscle drops underneath spinalis surfaces, then we'd know that we would get that needle through that muscle as well. So I'll come back out, and then we'll look at multifidus. Let me highlight that. Okay, multifidus. And so we will address multifidus in the lumbar as well. But it has its attachment all the way down into the body, under the body of the sacrum, even into the sacral sulcus. So SI pain, is it a true SI innominate shift or rotation, upslip, downslip, or is it an inflamed multifidus? It's where our palpation comes in very handy. So really posterior origin, as it travels up, it's going to finally, its final attachment on its short fibers is onto C2. It does not go any higher onto C1 or onto the occiput itself, but that's its termination piece there. So our deep muscles, obviously, again, if we talk about the transverse, the spinous process of C6, definitely we're going to hit all three of these muscle groups right here. And so that will be our first spot. And we'll talk about that again momentarily. If we look at the bigger, more superficial muscles, I will start. We mentioned, and let me come back to that one. Let's hit here first. Let me drop down. So here, the Splenius Capitis, with its origin on the nuchal ligament, the spinous processes of C7 through T3. So it's coming down a good bit of difference, a good distance, and inserts into the mastoid process of the temporal bone and the lateral 1/3 of the superior nuchal line of the occipital bone. And so again, we talk about this spinous process of C6 right here. If we use that, we know we're going to catch a needle into those muscle fibers. Okay, I'll fade that, and then we will look at the Splenius Capitis. This is one where we're going to have to, if we want to effectively needle this, especially in this session, we're going to need to come down fairly low. So we'll select here our spinous process of T4, so we know we get all those muscle fibers. Now, we're also going to catch multifidus when we needle here, perfectly fine. But to really catch the body of this muscle, we need to be down low. If we look at the actual attachment or insertion, it's a rather high area where we have quite a few important structures. Vertebral artery running right here. We have the brachial plexus and the upper cervical nerves, brachial plexus below, upper cervical nerves coming out above. So just not the wisest place to try to needle that. So we catch that in a secondary location further distally. If we move on down, so let's move on to the Lumbosacral Spine and the 5 structures that we're going to evaluate there. Here we'll look at interspinalis longissimus Iliocostalis Lumborum, lumbar multifidus, and it's not listed for some reason, but we'll also look at the Psis. So interspinalis lumborum. Here our origin is in the spinous process. Insertion is the spinous process. So as you can tell, there's one on either side of the spinous process above and below, and they simply connect and help extend that spinal column. Again, their innervation is a segmental posterior rami. As we look at longissimus lumborum, here the origin, the accessory processes in adjacent medial and of the dorsal surface of the transverse process of the lumbar vertebra and the ilium. It inserts, their tendons converge to form the lumbar intermuscular aponeurosis. Frequently the other component there is the is the Iliocostalis, and it almost acts as a large tendon in that area, and we can needle into that aponeurosis as well. Its innervation is its segmental right there. Action is at the primary extensor of the vertebral column and head. Acting bilaterally, they straighten the back, returning it upright from a flexed position. For the Iliocostalis Lumborum, its origin, the sacrum, the spinous processes of the lumbar and lower two thoracic vertebrae and their supraspinous ligaments, and the iliac crest. The inserts into the angles of the lower 6 or 7 ribs. It's innervated segmentally by the dorsal rami and the action. They also are primary extensors of the vertebral column and the head. Acting bilaterally, they straighten the back, returning it upright from a flexed position. And the multifidus, again, similar to the cervical spine. Its origin, the sacrum, the origin of the erector spinae, the superior iliac spine, the mammillary processes of the lumbar vertebra, the transverse processes of the thoracic vertebra, and the articular processes of the lower 4 cervical vertebra. Insertion is into the base of the spinous processes of all the vertebrae from L5 to C2, and their innervation is the medial branch of the posterior rami of the spinal nerves. Again, the site of radiofrequency ablation or medial bundle branch blocks. Action, they stabilize the vertebra and the local movements of the vertebral column. Global movements, they contract bilaterally to extend the vertebral column, and they contract unilaterally to produce rotation in the opposite direction. Primarily, they are our deep stabilizers. And then the PSIS, just a general location here. Again, there's not really anything that attaches to the superficial except an overlying cover of fascia, but we have gluteus maximus that attaches very near. We have gluteus medius that has a very near attachment that we'll get to in a different lecture. The latissimus has an attachment on the ilium as it comes down, so right in there as well. Iliocostalis comes very close, as does longissimus, and then much deeper multifidus. So a lot of potential areas for problem here on the PSIS. Almost every lumbar, lumbosacral, lumbopelvic problem that I deal with, I will needle onto the PSIS simply because it's such a tender point of concern for the patient. For our surface anatomy for our lumbar spine, I'm going to switch tabs here. See if this is where we are. Give my software a chance to catch up. Again, if you want a full dive into effective treatment through dry needling, excuse me, I strongly encourage you to get your hands on a good 3D anatomy program. I use Complete Anatomy partly because I have teaching rights with it, but I also have, of all the ones I've used, this has been one of the most affordable ones, and there's a lot of functionality that I like out of this one. But find any one that you want. All right, so in the lumbar spine, 5 structures of interest. Let me try to catch up. All right, turn that off. Okay, so let's start with the smallest of everything. In between the spinous processes are the interspinalis. They're composed of one on the right and on the left. You can tell, very small structure. I don't needle this all the time, but I do like to be able to needle it in the event that I've got some central spine symptoms, pain complaints that I just haven't been able to address with anything else. This is needleable. It is the only muscle that we will needle in the spine where we will needle in a superior approach. If we oriented our needle from superior to inferior, which is what we do for every other muscle, then we probably would hit spinous process, but wouldn't be able to land exactly into this structure itself. And so this is the only time we'll take about a 15 to 20 degree superior angulation to make sure that we needle into the interspinalis lumborum. We're going to keep this at less than 20 millimeters of penetration. Any more than that, then we'll be way past that muscle itself. And more than that, we run the risk, depending on the body morphology, of entering into the spinal canal. And that's definitely something we don't want to do. So interspinalis lumborum. We move from here. Let's go deep to superficial. So here we are again, multifidus. As we talked about, a origin on the sacrum itself, and even diving into the sacral sulcus. With that, covers a lot of territory. When we needle, we're going to come just one finger breadth lateral to the spinous process and needle inferior and medial to make sure that we land on that laminar surface. The muscle that sits just posterior or superficial to that is the longissimus. This software calls it longissimus thoracis. I was taught longissimus lumborum. Potato. It is the longissimus. And so it has a very similar makeup or footprint in the lumbar spine as does the multifidus, other than it is much more superficial. When we look at the iliocostalis a little bit more laterally, you can palpate the distinction between iliocostalis and longissimus. But its origin, spinous processes, well, on up, but of L1 through L5, and the dorsal surface of the sacrum and the iliac crest, and then it inserts into the transverse processes of the lumbar and the thoracic vertebra from the 2nd to the 12th ribs. And so let me take and hide iliocostalis here so that we can see where it actually inserts. And then again, transverse processes coming on up and onto the ribs themselves. And we'll see as we get into the thoracic spine, they continue on up as well, all the way to the first rib. So as the name implies, it's a long muscle. So we'll look further laterally, and I'm going to go to the right side here at iliocostalis. Iliocostalis, its origin is the iliac crest and the posterior lateral aspect of the sacrum. And so deep to here we'll find Quadratus Lumborum, a muscle that we frequently like to attribute to a lot of pain and a lot of pathology. It sits deep here, but the challenging question, is it the QL or is it iliocostalis? Well, there's some ways that we can treat that. Interestingly, we can dry needle them both through the same needle location if we choose. So a nice treatment option there. But the insertion on the transverse process of L1 to L4, and then the angles of 5th to the 10th ribs. So we come laterally here. Oh, let me rotate a little bit more, looking at it from an anterior view. Let me come forward so we can zoom in and see, similar to the longissimus, they're going to attach onto the transverse processes. And then as we get into the thoracic spine, we'll see they have their costal attachment as well. They don't travel quite as superiorly as does the longissimus, but we do also find those as a separate muscle group in the cervical spine. So we get to introduce those again in the advanced coursework. So we also wanted to look at PSIS. So I include the PSIS primarily because anytime we're dealing with any pathology in this mid-lower lumbar spine, lumbosacral, lumbopelvic region, very frequently we see a lot of problems with tenderness right at the PSIS. Let me come back to my full body here. Again, nothing really attaches onto the PSIS itself, but if we take a look at everything around it that does, the lats come down and have an attachment right over it. We talked about iliocostalis, longissimus, the multifidus itself has an attachment very close to here. Obviously, the gluteus maximus has an attachment right there. We look deeper. Gluteus medius is not terribly far away from that. So a focal point of pain right here. So people come in and they talk about that thumbprint of pain that we're taught to say that that's an SI joint problem. Well, it could be, but there's an awful lot of other things that are going on as well, just from a tissue standpoint that could be involved as well. So very frequently I will dry needle just onto the periosteum of PSIS, elicit an inflammatory response, get some healing going, and normally that is a good treatment approach for that. So we'll move on to our surface anatomy lab. Here we want to look at some anterior structures to help determine their location on a posterior aspect. I don't do an anterior assessment to help identify our posterior structures with each and every patient, but there are times where it's helpful to identify those structures. We'll look at our hyoid bone, which is going to correlate to C3 posteriorly, our thyroid V-notch, which will give us a better choice of a view for C4. A little bit lower, the smooth sides of the thyroid cartilage will correlate to C5. And then the cricoid cartilage further posteriorly to C6. We can drop down a little bit further into the sternal V-notch, and that will give us a posterior correlation to T2. We're not on that right now, but since the picture is up, we can look at below the clavicle, lateral to the sternum, the manubrium. We can identify the first rib as it comes off and then travels underneath the clavicle. We can find that space in between rib 1 and rib 2 to help us identify each rib, and we can carry that on down to the xiphoid process to help determine those spaces. So we'll start by taking a look at our surface anatomy of the cervical spine. We'll start with some anterior structures first to give us a point of reference for identifying posterior structures. And so let me bring up my pen. The structures anteriorly that we'll look at first will be the hyoid bone. Second, we're going to look at the V-notch of the thyroid cartilage. Thirdly, we'll look at the smooth lateral surface of that thyroid cartilage. We'll then look at the cricoid cartilage, and then lastly, the sternal notch further distally. So these would be our anterior structures. Okay, so let me clear that, and let's look at it from a lateral aspect. So how these are going to correlate to our structures posteriorly, the reference is going to be a little bit from a anterior inferior to a superior posterior angulation, simply because of the cervical lordosis that we have. But if you place your hand underneath the mandible, underneath the jaw, and let me drop that down just a little so we can see everything here. Okay, so there we are. So we look at hands underneath the mandible. You can have your subject swallow. You'll feel that hyoid bone move. That's going to have a direct correlation with the spinous process of C3. My line is not exactly straight, so let's try that again. Here we go. There we go. So there we have C3. The V-notch of the thyroid cartilage, and these are all palpable, you can palpate them on yourself, is going to orient to C4. The smooth surface of the thyroid cartilage itself is then going to align with C5, and then further distally, and it sits right about here as a smaller, harder structure, the cricoid cartilage, and that is going to orient to Spinous Process of C6. We drop down a little further distally. Again, the sternal notch sitting right here at the junction at the upper end of the sternum, the manubrium, where that's orientation will be relative to the Spinous Process of T2. Okay, so let's look at our surface anatomy from a lateral aspect. Some structures we'll be interested in here. Number one will be the mastoid process. Just inferior to the ear, we can palpate that. Excuse me. Just inferior to that will be the transverse process of C1. Another structure of importance, especially as we get later into our course, will be the lateral arch, our laminar arch. And so that's on most people that's fairly easily palpable. It can be tender, especially if someone is having some posterior lateral symptoms, but that is going to be an important landmark for us to discover a little bit later. So let's move from here. Let me clear that, and we will move posteriorly now, and let's evaluate some of our important landmarks here. So let's start first with the external occipital protuberance, easily palpable in this area. There are then going to be three lines of importance, really two, but there's three here, so we'll discuss all of them. First is the supreme nuchal line. Adjacent to the external occipital protuberance will be the superior occipital protuberance, and then further distally and much deeper will be the inferior nuchal line. So supreme, superior, inferior nuchal lines. Let's talk about the spinous processes posterior. C1, rather difficult to palpate if it can be palpated at all. Most commonly, C2 is our first spinous process that we can palpate. We can follow by palpating in between each spinous process and the interspinous space to find each of the subsequent spinous process. Of importance, we get down to C5, C6, C7, T1. Then we want to know, okay, well, how do I know if I'm on here? So the easiest way between C6 and C7, a person that's 40 years of age approximately or younger, when you extend the neck, C6 is going to move anteriorly, and then as you extend, it's going to come back to a normal position. C6 does tend to sit a little bit more anterior than C7 to begin with, but in a nice seated position with that extension, C6 will move forward. C7 tends to be the last of the vertebra that will have some rotation in it, and so if you place your fingers in between the interspinous space between C7 and T1 here, and then do some rotation, you should be able to feel the differentiation between the spinous process of 7 and 1 as well. As you've identified T1, you can move out laterally and palpate the transverse process of T1. If you move a little bit further laterally, then you feel the drop-off. That drop-off indicates the transition from the vertebra itself into the first rib. So that's the vertebral and rib junction interface. So that's rib 1. Likewise, if you proceed down into the thoracic spine, you'll notice that as well. If we've identified T1, we can look at the sternal notch anteriorly, and we know that is T2 as a reference spot. Okay, let's drop into the thoracic spine for our last little piece here. We caved in, we identified transverse process of C1 and the spinous process of 2, 3, 4, 5, 1, 2, 3, 4, 5, 6, and then here we are at C7, and then we get to T1, which is our first rib articulation. So for one of our D-level placements today, we want to look at something a little bit further into the thoracic spine. So if we look at the spine of the scapula. We can draw a line from the root of the spine of the scapula across, and the general location, see T1, T2, will be between the spinous process of T3 and T4. Generally speaking, we'll call it T4. So that is location. Now the spinous process sits much further inferiorly than the vertebral body itself, but for our point, the root of the spine of the scapula will represent T4. Surface anatomy for the lumbar spine. We will start by looking at our inferior aspect and then moving more cranially. So we look at, first thing we'll do is we're going to trace the iliac crest, and we're going to do this on both sides, and follow it down till we can identify the Psis. If we draw a helper's line between, let's draw that a little bit better, between the Psis, its orientation is roughly going to be at the level of S2. If we move S2, move superiorly, we'll drop off of that spinous process, and then we can palpate S1. Moving further superiorly, it's a lot smaller, but we palpate for the space in between S1 and the next identifiable spinous process, which obviously will be L5. L5 is fairly deep, and it almost feels like a pencil eraser. If you need to differentiate between L5 and S1 to make sure that you're in your right spot, then what we can do is do a springing action. Use the ulnar side or the hypothenar side of your hand onto that spinous process. L5 will move anteriorly and S1 will remain stationary. We can draw another helper line at the level of the iliac crest, and that will help us identify L4. So from there we can move further cranially, just palpating between each of the inner spinous space between the spinous processes to identify L3, L2, and then finally L1. To get a good idea of where we are as far as the thoracolumbar, the TL junction, we can find the 12th rib. We can follow it medially, and at the level of the spinous processes, the spinous process above will be T11, and the one below will be T12. Some more information, and I'm going to clear that information. Some more information. So the facet joints, the zygapophyseal joints themselves, are going to sit basically in line with the spinous process. Inferior aspect will be at the spinous process. The superior facet will be at the spinous process of the vertebra above. So they're going to sit about 2.5, 3 centimeters lateral from the middle of the spinous process on average. The transverse processes, L1, L5, not going to be palpable. L3, probably the largest of the transverse processes. Odds are that can be palpable. More often than not, again, similar, going to find that they're going to sit midway between the spinous processes. L2, L4 possibly palpable. L5 is going to be buried behind the ilium, and then L1 is just too narrow and hidden as well. And so those are the framework for the surface anatomy we need for this course to identify our needling spot, which is going to be adjacent to L4.
On our surface anatomy of our posterior cervical spine musculature, we can get a good idea of where we're dealing with posteriorly by our anterior structures. I don't necessarily do this with every patient, but it's a good frame of reference for us to utilize. So what we'll look at is our hyoid bone, our V-neck or our V-notch of the thyroid cartilage, the smooth side surfaces of the thyroid cartilage, then the cricoid cartilage, and then lastly the sternal notch. So if you come in with your patient, with your subject, and just gently place your finger and thumb underneath their mandible, you can then have them try to swallow. When they do that, you will feel the hyoid bone moving up and or down. You want to be careful. It is fragile structure, so don't try to choke your subject. But that will give you an idea here. So hyoid bone. If we look in a direction, and this line of movement is going to be slightly anterior inferior to posterior superior because of the angle of lordosis in the cervical spine. So we identify the hyoid bone right here. That will give us C3. We drop down into the V-notch of the thyroid cartilage. That will correlate to C4. We drop down laterally, and on the thyroid cartilage itself, we'll be able to feel a smooth aspect on either side. That's going to correlate to C5. We drop down a little bit further, and we're going to find a smaller but more rigid, a cricoid cartilage, and that's going to correlate to C6. If we drop down a little bit further to our sternal notch, if we translate that posteriorly, that will get us to T2. Okay, so on the lateral aspect, let's talk about our landmarks. Laterally, we want to identify and palpate the mastoid process. Right there. And then as we run distally, our first lateral structure we'll come to is the lateral transverse process of C1. And it's just going to be about a finger breadth below the mastoid process. Very frequently that can be a tender location. Another important structure is the articular pillar or the laminar arch. So we'll want to identify that and its anterior-most border. And there's a reason for that. So that would comprise our laminar arch, our transverse processes on that side. As we get further into the course and talk about scalenes, other structures, this landmark will become incredibly important. So from our posterior aspect, we have several things to look at. First, we want to identify the external occipital protuberance as the skull comes up and forms the crest. It will be the most notable point right in the center. For our sake here, put a little dot there. You don't have to mark that if you don't want to. So superior to that, we have three nuchal lines. The supreme nuchal line, which is a little bit harder to palpate, but you will notice a ridge that runs across from medial to lateral. At the level of the external occipital protuberance, you will palpate, again, a line running across on either side, and that is the superior nuchal line. A little bit lower as the skull starts to dive down in towards the cervical spine itself, and this is deep and this is considerably more difficult to palpate, we'll locate the inferior nuchal line. When we deal with suboccipitals, that line becomes more important for that. But we also want to evaluate and identify our spinous processes. So we come around. C1 is almost always impossible to palpate. An extremely thin person, you may be able to palpate that, but more often C2 is going to be our first spinous process that we locate. And so what we'll do is just march our way down. C3, C4, and C5. So we've got a few more to do. What I want to do in evaluating C6, C7, T1, however, is have them do some cervical extension. When you extend the cervical spine, for people, say, 40 years of age and under, C6 is going to move anteriorly. Over that age, because of degenerative processes, maybe there's some osteophytes, it doesn't tend to move quite as much, but that's what we want to look for, is a migration of C6 anteriorly. So I'm going to get my best guess of the interspinous space between C6 and C7. And I'm going to palpate onto each of those spinous processes. And so I'm going to have the subject then extend their neck, so we'll lift up, and then C6 does move anteriorly. This is easier done in the seated position. It requires less contraction of the erector spinae, the paravertebral muscles, but it still will move forward a little bit. So I know C6 and then C7 right below. So I can also evaluate C7 versus T1. C7 has a little rotation in it. So if I butt up against the spinous process, I can rotate. That spinous process is moving. If I drop down to my next and I try to rotate here, that one does not move. So this I can identify as T1. If I move laterally off of T1, I can palpate the lateralmost border of the transverse process. I drop off of that, and then I will be dropping onto the costovertebral junction of rib 1. So here is our transverse process. Here's the first rib, and then this comprises the vertebra itself, the laminar pathway here. So I also get interested, so here's T1. We talked earlier about the sternal notch. Its posterior border would be T2. So I know we're sitting here at T1 because we did our rotation, it didn't move. That would make this T2, but I'm interested in T4 for our purposes for this, the dry needling we'll do here. I want to find the spine of the scapula. I'll use this one over here. And so my spine of my scapula, here is my medial scapular border coming here. Okay. Spine of the scapula is going to travel along this direction. I'm going to carry that all the way to what I'll term the root of the spine of the scapula. And we can do it on each side. But basically, between T3 and T4 resides, if we draw a helper line, the spinous process of T4. So if I'm looking for T4, I find my spine of my scapula, and that gives me T4. Again, this is where we found T1 and 7. There's 2 and 3. Okay, in the lumbar spine, where we want to start identifying our landmarks is we'll start distally and make our way more proximally. So first thing you want to do is palpate for and identify your iliac crest. We'll come around, we'll mark those on each side. Ultimately, our goal is to identify our Psis. So we have a really nice landmark here. I'm going to draw a helper line across. So at the midline of our helper line is S2. Try to draw that upside down. S2. If we come from S2, we'll drop off onto S1, and then between the next step up is onto L5. Now L5 is a smaller spinous process. If you want to differentiate between S1 and L5, you can come in with your thumb and another helping finger to bounce or spring that. L5 will move. S1 will not. So there's my L5. Okay, so here's 1, here's 5. Now, I'm going to draw another helper line at the apex of the iliac crest. In the midline, that will be L4, right there. So we've got L5, L4. We can verify our location here simply by palpating the spinous processes, moving superiorly. So here we have 4, 3, 2. That should be 1. If we want to verify, what we can do is locate our 12th rib. So we identify that, and then we mark it as it's coming up towards the center of the spine. Okay, coming up to here. So where that 12th rib intersects, the spinous process superior will be T11, and the one inferior will be T12. So here's 11, 12, 1, 2, 3, 4, 5, S1, S2. In the lumbar spine, we also consider our facet joints. So in our facet joints, they're going to basically be at the level of the spinous process. So here we have L2. At L2, and it's about 2 to 3 centimeters lateral from the spinous process. That'll be the location of our inferior facet joint for L2. The superior facet joint will be at the level of L1. And so, roughly speaking, the facet joints correspond to the spinous processes as they travel down the spine. Our transverse processes are also going to be at the level of the spinous process. Because of the shape and the length of the spinous process, L1 is going to be 1 to maybe 2 vertebrae higher than the spinous process. So let's say for L2, 1 to 2 finger breadths, more likely 2 finger breadths, I should say. So the transverse process will be more lateral, but it's going to be superior to the spinous process. L1 and L5 really are not palpable. L5 is hidden by the ilium. L1 is too involved with the 12th rib. The transverse process of L3 typically is the largest, and it will be fairly deep, but frequently palpable here. L2, L4 can be palpated. An extremely thin patient, you can get to those. Most of us bigger bodied, and I'm speaking to myself, people harder to get to those, but that's roughly our distance as far as landing on the transverse process. Okay, 1 second. I'm going to jump out here if I remember how to do this. I'm going to move over to here. Okay, so talked about the, if I can get everything in here. So here's just the skeleton of the lumbar spine. Talked about the location of the facet joints, zygapophyseal joints, and their distance away from the spinous process. As we'll talk about in a minute, when we're dry needling into any area in the spine, okay, so yeah, technical errors. So when we're dry needling into, specifically down into the multifidus, or in the case of, in the lumbar spine, multifidus and longissimus, I want to land down onto the lamina. The lamina is my landmark. That is my backdrop. And so if I don't stay too close midline, if I come out laterally, obviously I've got an issue. So knowing my distance away from midline is important for safety, to avoid some structures that we just don't want to do. And we'll talk about specifics there momentarily and make sure that we know how we're going to land on there. Okay. So now let me get back. Share. There we go. Okay, so some general considerations. Needle placement is determined. Let me change that. You don't need to look at that anymore. There. Okay. Needle placement location is determined first for consideration for safety to avoid the danger zones, and second is for maximum therapeutic effect. It's frequently determined as a certain number of finger or thumb breadths from specific anatomic structures identified in our palpation lab. And when we're referring to that finger or thumb breadth, it's always important to remember it's the finger or thumb breadth of your patient, your subject, not you, the clinician. When needling using the Spinous process as our reference in all of these, that's what we're talking about. Excuse me. The distance is from the lateral aspect of the superior most aspect of the spinous process. So this joint right here, that space at the superior lateral point, that's where we're going to start measuring from. And so normally we'll do 1 finger breadth every now and then we'll see something 2 finger breadths. And so superior aspect is where we're talking about. When we're inserting a needle, first determine the desired needle placement location. We're going to use the index and middle fingers to apply the firm pressure. We're going to do that splaying technique. Y'all have all submitted your videos. We're looking good there, so I'm not going to go over that again. You did well on needle manipulation, pistoning, bidirectional rotation, unidirectional, and then again, care with the pistoning and so forth. So let's talk now specifically about our cervical spine treatment. I have, for purposes of this lab, I've identified 2 places that we can needle the entire cervical spine, excluding the suboccipitals, excluding, I should say, the posterior cervical spine, and gets our maximum effect. Now, these needle placements, we can do this anywhere up and down the cervical spine. Matter of fact, we can do it all the way down the entire length of the spine. But it's often beneficial to treat with as few needles as possible for patient comfort. And so I've identified 2 locations where we can get all of the muscles here in the posterior cervical spine. So for that treatment, our needle inclination is going to be 1 finger breadth, and this is this spot right here. 1 finger breadth from the spinous process for multifidus, and it should be at a 15 to 20 degree medial and caudal angulation in each plane perpendicular to the skin surface or relative orientation of the vertebra to contact the base of the spinous process. Again, as we are looking on the skeleton, our goal is to land down on lamina. So a patient will ask, well, how deep do you go? Well, that as deep as that multifidus is, if I don't hit lamina, I probably am not hitting it. And that's my main goal, is to hit multifidus. So lamina is our goal. We always want to make sure, again, angulation must be inferior in medial and caudal. Any other angulation would increase the risk of the needle advancing into the spinal column, into the dural space. There's one exception to that. Interspinalis, we will go more into a superior angulation, but we're going a very short depth and using a much shorter needle. And we will cover that. And so, so for our first location, we're talking here. Let me get me out of the way. There we go. Here, Splenius Capitis, Spinalis Cervicis, Semi-Spinalis Capitis, Semi-Spinalis Cervicis, and the multifidus. We can get all of those structures in 1 needle placement. Again, if a patient's having a point of pain that's superior or inferior, absolutely we can needle into that. But if we want to get our biggest bang for our buck, these 2 locations will do the bulk of that posterior musculature. Our patient position is going to be prone. Needle length is going to be 30 to 50 millimeters. Myself, it takes a full 50 to 60 millimeters to land on the backdrop in my cervical spine. A smaller person, and if you have different structure within the vertebra, I know it sounds strange, but as you needle, you will see more things happening. Different depths for different people. Here are precautions: the deep cervical artery and vein, the anterior ramus of C6 and C7, the accessory nerve, cranial nerve 11, and then the central canal. Here we're going to needle at the spinous process of C6. We're going to be 1 finger breadth lateral, and we're going to go from posterior to anterior all the way down to lamina as a backdrop. It's an antero-infero-medial angulation. C6 spinous process, just for our reference, moves anteriorly with extension as compared to a stationary C7. It's just same information, just a picture. The Splenius Capitis, the Spinalis Cervicis, Semi-Spinalis Capitis, Semi-Spinalis Cervicis, and the Multifidus will all be needled in one location. Patient's going to be in the prone position. Needle length, we're going to be 30 to 50 millimeters. Backdrop will be onto the cervical lamina. So we're going to locate the spinous process of C6. It's going to move anteriorly with extension as compared to a stationary C7. Needle placement will be 1 finger breadth lateral from the spinous process of C6. Angulation will be about 15 to 20 degrees, both caudal and medial, down to the lamina as a backdrop. So I will absolutely say one of the scariest things when you first start dry needling is when you get into the spine and you drop a needle down into somebody's spine and aiming to land on bone. Don't practice this at home by yourself. Whenever we get in together for lab, we'll walk through it. It's not as scary as it seems, but we will get through it, and we will show that it can be very safe and extremely beneficial. While this is rolling again, I'll turn this off in a second. I will have these. Actually, I already have these in the portal for view separately from this video. So you can take those, slow them down, and look at them as you would like. But those will be available. So that's position number 1. Next, we'll move down, and again, that position, that 1 finger breadth away lateral from the superior aspect of the spinous process, we can carry that all the way from each segment all the way down if we so choose. I picked these 2 for, again, maximum bang for the buck. So the second one we'll look at will be off the spinous process of T4. This is specific for splenius cervicis. We're still going to catch multifidus. We're going to catch some other structures in here, but splenius cervicis, if you remember, had this origin down low, and then it attached onto the transverse processes of C1, 2, and 3. So instead of coming up high, we're going to catch it much lower, being a decent sized muscle for stabilization. For splenius cervicis, the patient's going to be in the prone position. Needle length will be, again, 30 to 50 millimeters. The backdrop is going to be onto the thoracic lamina. Locate the T4 spinous process as it sits 1 to 2 finger breadths distal to the root of the spine of the scapula. Needle placement will be 1 finger breadth lateral from the spinous process of T4 in a P to A trajectory. Again, 15 to 20 degrees caudal and medial angulation down the thoracic lamina as a backdrop. Since we've got that there, if you are dry needling, this very helpful model that we used does have a mole or two here and there. Don't needle into the moles. There's no therapeutic benefit to that. The last thing we want to do is cause some sort of irritation. So definitely staying away from moles. From time to time, we will find that we have a situation. I was needling. Actually teaching a class at Tarrant County College, and did a demonstration on a gentleman who had lots of very prominent superficial veins. Anytime that you have obvious vein structure in the way, especially superficial, definitely re-angle your needle placement. Still strive for the same depth in your goal, but be aware of that superficial vein situation. So in the lumbar spine, we had 5 structures down here. We're going to get them with 4 needle locations. We'll get multifidus and the longissimus in one. We'll catch interspinalis. We'll demonstrate that. And then iliocostalis will be the only one that we're doing here where we're moving away. And this one does not have a backdrop onto the lamina. This will have a dry backdrop, if you will. We're just going to go a certain distance to get through the bulk of this fiber. Again, in the lumbar spine, we're going to use L4 as our landmark, similar to in the cervical spine. We can take this needle placement anywhere up and down the lumbar thoracic spine. We talked about the danger zone of the TL junction when the lamina really start to get significantly more narrow at that location. Because now we're going to try to drop a needle down onto that, that becomes a little bit more critical. So we want to know where that is. So we use that 1 finger breadth lateral from the spinous process with that angulation both medially and inferiorly, and that gives us our safety. In the lumbar spine, for the longissimus and the multifidus, patient is going to be here in the prone position. Needle length will be 40 to 60 millimeters with a backdrop onto the lumbar lamina. We're going to palpate for the spinous process of L4 at the level of the iliac crest. Needle inclination will be 1 finger breadth lateral from the spinous process and should be a 15 to 20 degree anterior, medial, and caudal angulation in each plane, perpendicular to the skin surface or relative orientation of the vertebra to contact the base of the spinous process on the lamina. So the next we'll look at iliocostalis. Again, iliocostalis is going to have a little bit different of a grasp. Iliocostalis is the lateralmost of the erector spinae group, and when we needle that, it is important to identify that lateral border, and we'll demonstrate that with a profundus grip to identify it, and we'll needle in between those 2 fingers. For the iliocostalis in the lumbar spine, a patient again is going to be in the prone position. Needle length is about 30 millimeters and there is no backdrop. What we're going to do is grasp the lateral border of the erector spinae group with a profundus grip. We're going to apply some firm pressure and splay the index and middle finger. Here we're then going to needle 3 to 4 finger breadths lateral to the spinous process of L4 with a 45 to 80 degree medial and a 15 to 20 degree caudal angulation in each plane perpendicular to the skin surface or relative orientation of the vertebra. So with Iliocostalis, it is easy. It's necessary to use that profundus grip to reach over, to bracket over that muscle group out there. It's in the lowest of the lumbar spine. It's a little challenging because of all of the connective tissue that's coming together right there. If you get a little bit higher up into, say, L2, L3, as you and palpate on a patient, or a friend or colleague, as you palpate and bracket that muscle bulk, you'll be able to identify that lateralmost border, and you're just going to needle directly into the structure right there. Then finally, interspinalis. Again, I don't needle this all the time. From time to time, I will if it's giving me some problems. It is necessary for us to be able to needle this structure because it can be the source of some problems. Here we're going to be needling here, demonstrating between L3 and L4. But L3, L4, L4, L5, the space between the spinous process is very tight, especially in the prone position. I'll look at my video in a second. It may be necessary to have your patient with a pillow under the stomach to flex that spine to open those spinous processes up a little bit. Our caution here, depth less than 20 millimeters. If you're using a 3 centimeter needle, you want to leave probably at least half of it out. So you definitely don't want to sink a 60 millimeter needle in there, because I promise at that point you very well may be into the spinal canal and you've got some problems. So fairly superficial. You can tell it's right at the tip of the spinous process. For the lumbar interspinalis, position is again going to be in the prone position. Needle length here is less than 20 millimeters. We definitely don't want to enter that spinal canal. There's no backdrop. We're going to use our fingers to locate the interspinous space between L3 and L4. When dealing with the spine, this will be the only time that you will have a superior needle angulation here with a 15 to 20 degrees anterior superior angulation, perpendicular to the skin surface. Caution for depth here, definitely less than 20 millimeters to avoid the spinal canal. Okay, and then lastly, down to the Psis. Again, I needle Psis. If there's some back stuff, I promise that there's some Psis tenderness. Needling onto it will provide some good relief, and that's just a good location. Again, we'll follow that iliac crest, overlocate that Psis, and normally I may needle onto that in 2 or 3 different locations. I might do some pistoning onto that surface. I might do some tenting and some unidirectional rotation and get some tissue movement, but a great location to put in your tool bag here. For the Psis, obviously, patient's going to be in the prone position. Needle length here, 3 to 5 centimeters, depending on patient habitus. Backdrop obviously is the Psis. We're going to palpate the vertical length of the Psis, and we're going to use the needle to needle through the connective tissue and peck on the periosteum, locating 2 to 3 different areas on the Psis. From a treatment standpoint, I would say that rarely is the Psis a lone problem. Something else is going on to create that inflammation in that area. So you may look at needing to do this L4, this longissimus, and multifidus. You might need to be looking at iliocostalis. It may be some of the other structures that we won't talk about for just a little bit, but remember that Psis because it can be quite the effective treatment approach. And so when we look at these, I don't have the PSIS needled, but we've got interspinalis here in the center. We've got multifidus and longissimus laterally, one single finger breadth away from the spinous process. Needle inclination, as you can see, is inferior and medial. And then iliocostalis itself, I came up a little bit. So I'm probably a little bit more at T1, T2 to catch iliocostalis. You can tell it comes fairly lateral as it comes down to its attachment on the ilium. So, while we've gotten through everything, even though we had some issues, I do have one more thing to do momentarily, but I want to go over what we'll talk about, I believe, 2 weeks from now. Here we'll look at, start with the junctional zones, the shoulder and the upper arm. Again, the same basic content, surface anatomy, 3D, three-dimensional anatomy. We'll look at some supporting evidence, clinical decision-making. And then our structures, here we're going to look at the upper trapezius, latissimus, again, the thoracic, multifidus, spinalis, longissimus, and iliocostalis. Anteriorly, we'll look at pectoralis major. And then in what I term the pelvic rotator cuff, the glutes, TFL, piriformis, and then the small, deep hip rotators that we tend to needle as a single unit at this stage. We get into the shoulder, we'll look at deltoid, infra, teres major and minor, and then in the upper arm, coracobrachialis, biceps brachii, brachialis. I guess we'll look at biceps brachii twice. And then, there are two heads, and then brachioradialis. And so since I mentioned brachioradialis, we have several. I'll go over the homework in just a moment. We've got some identified there, but I'm going to bring my ever able-bodied assistant in to help me here. So what I'm going to have you do is a self-dry needle of the brachioradialis. So in this part of your homework, your assignment will be to dry needle yourself if you haven't already. I know a lot of people in the course have already done some dry needling and needled themselves. So what we're going to do as let me get this, let me switch here. The camera. So right now, is this where I need to be? Am I screen sharing?
Yeah. Oh, no, you need to stop screen sharing
Okay.
to make yourself big. So just hit the red stop share.
Stop share. Okay. And view. Speaker view. Nope. Okay, there we go. Okay, so what I'm going to have you do is needle for brachioradialis. You can see that. All right. So how do we identify brachioradialis? Where we're going to go into a completely neutral position. Go ahead and place your arm on a table. We're not going to be pronated. We're not going to be supinated, just completely thumbs up. If I want to identify brachioradialis, I'm simply going to resist radial deviation. And as you can tell, it's going to pop up very prominently right here. And so first thing we want to do is identify the cubital crease. Now I'm going to draw it. I do need you to draw it. So identify your cubital crease. Okay, then what we want to do is come down 2 finger breadths. So it's my brachioradialis. I'm going to use my 2 finger breadths. I'm going to come down in that direction. So I'm going to mark down to my 2 finger breadths. That'll give me my point. I'm going to check it again. Needle is popping up really nicely. That's my needle location. My needle orientation is just going to be sky side down towards the table. I may hit radius as a backdrop. We're just going to advance this needle about 3 centimeters. So if you don't hit backdrop, don't worry about it. I just want you to have a little practice in this technique, and who better to practice on than yourself. So I'm going to get rid of my feather. I'm going to find my location. Do you like what we got there?
No, you turned blue.
It turned blue.
There we go.
There we go.
Okay.
All right. So obviously I can't splay myself with my hand over there, so I'm going to do it without. I'll double check one more time. Good to go. Boom, I'm in, and I'm going to advance about 3 centimeters. And there's backdrop. I would encourage you, so that you know how this feels. I'm not worried about pistoning, but do a little unidirectional rotation and bidirectional rotation as well. And then retract the needle. Okay. Now let me go back to share. Now everybody is freaking out now because of needling yourself. It's not that bad. I always say that it's important to, let me change that. Let me get back to me. There. I always say that it's important, regardless of what the modality is, that we do it on ourselves. Every needle protocol that I've developed, I've done or had done on myself. And so if you haven't been dry needled before, I think this is a great way to do it. So your post-lecture assignment number 1, and these are all on the portal. According to Zune, name 4 positive outcomes of dry needling in patients with chronic low back pain caused by lumbar disc hernia. 2, name the peripheral nerve in the dermatome of the dorsal surface of the last phalanx of the pinky finger. 3, when dry needling multifidus, what is your primary landmark and how far away from it would you place your needle? Then I want you to submit a picture on the dry needling arena of the following structures that you've marked after identifying them on a volunteer subject, so your surface anatomy. So I want you to identify and mark C6, T4, and L4, and then the iliac crest down to the Psis. And then lastly, we're going to demonstrate a self dry needle insertion into your brachioradialis. Apologize for the, let me stop the share there. Apologize for the technical issues that we had with the sound and so forth. I will redo some of this so that you get good quality sound on the recording that you can play back if you want to. Again, on the portal, you're going to find a lot of this dry needling information is already there. The needle sticks are already listed, and you can view those, and they'll remain there ad infinitum. So I hope that wasn't too much all at one time, but go through that homework and start posting. I appreciate everybody getting everything posted after lecture number 1, and then we'll get ready to get into shoulder and upper arm next session. Any questions, feel free to email me, hit me on the Facebook group, however you want to do that, and I'll see you again in a couple weeks.